Finding a hard, irregular lump on the body is often the first sign of testicular cancer. It rarely causes pain, which allows the disease to develop unnoticed in men between the ages of 15 and 35, a demographic that typically reports feeling at their physical peak. The testes function as the primary male reproductive glands, responsible for secreting testosterone and housing the germ cells that initiate the process of creating life. This diagram illustrates the transformation. When these germ cells mutate, they begin a cycle of rapid, uncontrolled division, forming a dense tumor mass that eventually compromises the surrounding tissue. If the growth is ignored, the biological consequences shift rapidly. The cancer can leave the localized area to target major organs, specifically the lungs or the brain. While genetics and undescended testicles are established risk factors, clinical data reveals another correlation. Taller men face a statistically higher risk of developing the disease. Because the tumor is often hidden and painless, mapping its biological progression is the only way to intercept the disease before it becomes lethal. The medical interception begins with a scrotal ultrasound. This allows doctors to confirm the presence of a mass and distinguish it from non-cancerous conditions like cysts. Clinicians categorize the tumor into two biological types, which determine the speed of the cancer's progression. This side-by-side comparison shows the difference. Seminomas, on the left, divide slowly and tend to stay localized. Non-seminomas, on the right, are more aggressive and spread through the body at a much faster rate. Following this classification, a staging CT scan is required to determine if the cells have migrated beyond the testicle and into other systems. Identifying the cell type and mapping the current location allows doctors to decide how aggressively they need to treat the remaining cancer. This diagram shows the 4 stages of the cancer spread. In stage 1, the tumor is isolated entirely within the testicle. At stage 2, the cancer moves upward into the retroperitoneal lymph nodes located in the abdomen. During stage 3, the cells continue their ascent through the lymphatic system, reaching the nodes above the diaphragm. Finally, at stage 4, the cancer breaks out of the lymphatic system and enters major organs, most commonly the lungs, liver, or brain. To stop the source of the spread, surgeons perform an inguinal orchiectomy, the removal of the affected testicle through an incision in the lower abdomen. To maintain typical physical appearance and provide psychological reassurance, a prosthesis can be placed in the scrotum during the same procedure. Pathologists then analyze the removed tissue to determine if the patient requires follow-up cycles of chemotherapy or radiation to target any remaining microscopic cells. By identifying the exact biological stage of the tumor, doctors can remove the primary threat and plan a targeted strategy for any systemic spread. While surgery removes the primary tumor, chemotherapy is often necessary to eliminate remaining cancer cells by circulating powerful drugs throughout the body. This treatment can have severe side effects. While it successfully destroys cancer cells, it can also lead to permanent male infertility. However, patients can safeguard their future fertility. By utilizing sperm banking before starting chemotherapy or radiation, they can safely store sperm for future use. This combination of surgery and targeted medicine is highly effective. Today, testicular cancer has a cure rate exceeding 90%, even in cases where the disease has already spread. The key to these high survival rates is early detection. Regular self-checks in the shower allow for the discovery of lumps before the cancer has a chance to migrate. Testicular cancer targets men at the height of their physical health, but through consistent self-exams and modern clinical science, it has become one of the most survivable forms of the disease.